We'll continue our discussion on altered mental status and other causes, and this is a pretty important one that you will see quite frequently. This is actually part of the cardiovascular system in leading to the signs and symptoms of a patient having a stroke. Now, this was formerly called a cerebral vascular accident, or CVA. It's referred to now as a stroke. It's the death or injury of brain tissue that's deprived of oxygen. Now, just like we see with patients who have heart attacks, stroke can be caused by a blockage that is called an ischemic stroke, and this occurs when a clot, also known as an embolism, occludes or blocks the artery. There is a different type of stroke that a patient will have, and the good news about having a stroke is that the vast majority of strokes are ischemic strokes caused by blockages and not hemorrhagic strokes, the second type that's caused by bleeding into the brain. This type, as I said, is known as a hemorrhagic stroke. And this comes about as a result, most of the time, of a chronic and long-standing problem with high blood pressure. Now, hemorrhagic stroke comes about when a weak area of an artery in the brain begins to bulge out, and eventually it ruptures, causing bleeding into the brain. Different patients have different signs and symptoms. One-sided weakness, known as hemiparesis, headache caused by bleeding from a ruptured vessel, are some of the ones that are going to be most commonly seen. Now, again, as you're going through here, as you're studying, make sure that you are being very, very familiar with the medical terms and not just the description. So when I say hemiparesis, make sure that you understand that I'm talking about weakness that's on one side of the body or the other. Other types of symptoms that you would see with patients that are having strokes include difficulty communicating, either by not being able to say anything whatsoever, or they may get the words mixed up. And this is known as expressive aphasia. Basically, it's coming out from the patient, and they have this inability to express themselves verbally. A second type of aphasia that you need to know about are the inability to understand what you're saying, and therefore saying things that are inappropriate to the situation. And this is known as receptive aphasia. Receptive aphasia. Basically, I can hear the words that you're saying, but they don't make sense to me, and therefore I will respond differently. Now, there are some signs and symptoms that lead up to patients having a full-blown stroke, and one of this is a condition known as a transient ischemic attack, also a TIA. In a TIA, the patient may look like that they're having a stroke because they have all the typical signs and symptoms of the stroke condition. However, the difference is the patient will always in a TIA have complete resolution of symptoms with no treatment within 24 hours. And normally it's much, much quicker than that. It can actually resolve itself in a matter of 30 minutes to an hour. Think of an ischemic stroke as the same way that you would think of a blockage in the heart leading to death of tissue. There's no blood getting through, therefore tissue dies off. A TIA would be very, very similar to our cardiac patient that is having angina. There's a little bit of blood that's getting through, but if the patient rests, they reduce the oxygen demand of the heart. Now, basically what happens is that the symptoms will resolve themselves and they go away. TIAs are very, very dangerous. And in particular, they're dangerous in males because if the symptoms go away, men have a tendency to be more stubborn, and when the symptoms go away, they just simply now no longer feel like that they need to go to the hospital. A TIA is an indicator that the body is being set up to have a major stroke sometime in the near future. So these signs and symptoms, even if they resolve, should never be ignored. The patient should always be transported to the hospital or encouraged to go to the hospital if they won't go with you by ambulance. And as I said in a TA, you have these small clots that temporarily block circulation to part of the brain and cause stroke-like symptoms. Now, when the clot breaks up, and occasionally it will, the patient's symptoms resolve because the part of the brain that was affected only had a short period of hypoxia or decrease in oxygen, and there was no permanent damage, just like we would see in angina within the cardiac patient. Now, like I said, and it bears saying again, this patient is a significant risk of having a full-blown stroke. If your patient refuses to go to the hospital, try to get them to go to the hospital by car. And if they do go by car, follow them to the hospital just in case the symptoms begin to resume. Now, if you got a patient that has symptoms of a stroke, if they're present, then you need to always assume the worst and work off the premise that it is indeed a stroke. We can't really identify whether our patient's having a stroke pre-hospital until we can get them into a CT. Now, what are we looking for here is the 3 signs and symptoms that we would normally see with these particular patients. This particular stroke assessment tool that you see on your screen is known as the Cincinnati Pre-Hospital Stroke Scale. It's very, very sensitive to identifying your patient having a stroke. As a matter of fact, if only one of these 3 things are present, then your patient has about a 65 to 70% positive indicator that your patient's having a stroke. So the first thing we want to do is we look at facial droop. Basically, what we would want to do in that situation is we would ask our patient to give us a really, really big, exaggerated smile. In doing so, if we have any subtle facial droopage on one side or the other, this exaggerated smile will reveal it. So looking for facial droop. Second thing we want to do is assess our patient for arm drift. Ask your patient to close their eyes and to hold out both arms out in front of them. Watch one side or the other, or one arm or the other, for drifting downward for your indicator that this would be positive finding. Now, one of the things that I would strongly encourage you to do would be to stretch out your arm underneath the patient's arms, especially if they are elderly. Sometimes patients will hold their arms and then all of a sudden they'll just drop down very, very quickly. If they are older, if they're on steroids, their skin may be very, very thin, and hitting a hard surface may result in a skin tear, which can become a source of infection leading to sepsis for these patients. So just kind of think ahead in that regard. The last thing that we would do is that we would assess their speech. And basically what we utilize is a phrase that says, "You can't teach an old dog new tricks." Now, there's nothing magic about that phrase at all. It's just a standardized phrase that will be repeated once they get to the hospital, and based off of your documentation that you find with your patient as to how well they were able to either say the phrase, or if they slurred their speech, or if they mix the words up, then they'll have them repeat that phrase at the hospital to compare it to what you found pre-hospital-wise. So other signs and symptoms that you're going to see with your patient having stroke, they're going to be confused. They're going to be frightened. They're going to be very, very scared. So make sure that you are addressing that, assuring the patient that you're taking the very best care of them that you possibly can. Never make false claims, false hope, false promises to your patient, but you can always basically say, we're going to give you the best care that we possibly can, and we're going to get you to the hospital as quickly as we can as well. Sometimes these patients will have incontinence of bowel or bladder, and they'll urinate themselves or they'll defecate on themselves, which will be very embarrassing for these particular patients. Make sure that you keep them covered up so that it will help to reduce some of that embarrassment. Patients will often have a really high blood pressure with strokes as well, and this is one of the reasons why it's imperative that you don't stop a nosebleed. And you're thinking, well, what does nosebleed have to do with a stroke? But you don't want to stop a nosebleed before you check a patient's blood pressure, because if the vein has ruptured within, or even an artery is ruptured within the nose, it's much better to let that area of the nose continue to bleed and serve as a pop-off valve rather than stop the bleeding, and then later on we have a rupture of a vein or an artery in the brain leading to a hemorrhagic stroke. If your patient is unresponsive, they may not be able to maintain their airway, leading to snoring respirations. Again, use the proper method of maintaining the airway in that situation, whether a head tilt chin lift or jaw thrust, if you're looking for potential trauma that has occurred. And then lastly, always, if we have a decrease in the amount of oxygen or glucose that's going to go to the brain, then our patient is going to run the risk of having a seizure. So what do we do for our patients? Well, first of all, we're going to treat your patient as you would any patient with similar symptoms. For a conscious patient who can maintain his airway, we're going to calm and reassure the patient. We're going to monitor the airway. We're going to give the patient oxygen if their O2 sat is below 94%, or if they are having difficulty breathing, or if they tell you they feel like that they're having difficulty breathing. Transport your patient as soon as you possibly can to a stroke center, and that's going to be your responsibility to make sure where those stroke centers are, that you know where the stroke centers are in your particular area. What we want to do is that we want to look at the onset of stroke symptoms, ideally getting them into a place where they can be administered thrombolytic drugs in less than 3 hours. The risks go up beyond 3 hours. However, in certain places, such as in teaching hospitals, level 1 trauma centers, they have specialty services there that would enable them to be able to go beyond that 3 hours. So that's, again, a call on your part that you would need to make that would help you to understand and to know what's going to be the best for my patient. However, make sure that you document and you share that documentation both in written and verbal form as to the time of the onset of symptoms. Now, if you've got a person other than the patient who provides that onset, you need to document who that person is, how to get in touch with them, how they can be contacted, or ideally bring them with you to the hospital. So some of the things that we're going to be looking at here would be some other causes of altered mental status, but we'll stop right here, make this kind of a short video, and then we'll pick up with the very next one.